Well, I'm going to go ahead and get started. Welcome, everybody. Today's webinar is New Research on Mental Health and Construction, Part 2. I'm Chris Cain, Executive Director at CPWR, the Center for Construction Research and Training, and I'll be moderating today's webinar. As the title implies, this is our second webinar on some new mental health related research that CPWR funded as part of a special series that we funded with a private sector donation to CPWR. We sent out a call for research projects nationwide, had an incredible response, and these are two of the 5 projects we chose to fund with that special donation we received, and we're really excited about today. The first of the 2-part series of webinars was done in March, and there were 3 presenters in that webinar. It's on our webpage. You can link to it, or it's linked to through our webpage. It's on our YouTube channel, and I'm certain Jessica will be. We actually have slides at the end of the presentation that will show you where to link to, and we'll pop some links into the presentation so you can find our webinar series if this is your first one with CPWR. So today we'll be hearing about the effectiveness of suicide prevention training and peer support programs in the construction industry. And now it's my pleasure to introduce today's panelist, Dr. Behzad Esmaeili. Did I get that right? Behzad. I just call you Behzad.
No, that's correct. Yes, that's correct.
Is an associate professor of civil and construction engineering and has a joint appointment with industrial engineering at Purdue University. And Dr. Bradley Evanoff is professor of occupational, industrial, and environmental medicine, assistant dean for clinical and translational research, and director of the Division of General Medical Sciences in the School of Medicine at Washington University in St. Louis. So I hope I got that right for both of you, and I'm going to go ahead and turn it over to Behzad to share your slides and get us started today. Thank you so much.
Sure. Thank you so much. I'm going to present with the help from one of our team members, Johnson Adetutu. So Johnson, if you can share your slides, perhaps we can start.
Yep.
And thank you so much. If you start from the first page. Thank you so much. So we started, big thanks to CPWR for providing financial support for this project. And if you go to, yes, thank you so much. So the title of our project was Suicide Prevention Practices for Iron Workers. And big thanks to CPWR for providing financial support and make it possible for us to conduct this study. For this study, we had colleagues from Public Health, Department of Public Health at Purdue University, Dr. Laura Schwab-Rees, and also Maritza Romero, who was a master's student who helped us with this study. And Johnson Adetutu is our presidential scholar PhD student who also helped with conducting this study. And he's going to present most of the research that he has done and data analysis that he has done for this study. So I give it back to Johnson so he can continue on this. But just want to say big thanks to CPWR to make it happen. For myself personally, that was a eye-opening experience, this study. When we asked Living Works to provide a training, we had a huddle of iron workers that started to share their experience about suicide. And almost all of the 10, 15 people in that huddle had committed suicide or had seen some people who committed suicide, one of their close friends or colleagues or things like that. And they started to share stories, what happened and what is the path to move forward and how they think we should move forward. And that was a really moving experience for me. And Johnson is going to present the data analysis that we have done for this study and share the results with you. Thank you so much. Johnson.
Thank you very much. Yeah, my name is Johnson, and I'm happy to be here. So yeah, statistically, we could see that suicide is a major concern around the world. Globally, we could see from the graph that suicide claim one life every 43 seconds. And in 2022 alone, 6,000 US construction workers died by suicide. I mean, that number is 6 times higher than the total number of workers who died on site construction accidents. So, and among all construction trade, iron workers have the highest suicide rates, which is, a shocking 5.7 times, higher than the national average. So now that we've established the alarming statistic, it's important to understand what are the causes of suicide in construction. And this include, personal struggle like alcohol and drug use, relationship problem, low job control, and even, the unstable, work environments. But for iron workers, these causes are more intense because they deal with, hazardous conditions like radiation, toxin, and heavy vibration. And, this factor can help explain why suicide rates are high among iron workers compared to other trades. So it's true that a lot of research has been done on suicide prevention in construction, but we found a lot of gap that many of these, prevention strategies are not, trade specific. And, even the one that are construction focused, they lack targeted, support for high-risk worker like a iron worker, because most of these, strategies are too generic. So because of that, we try to identify and evaluate the best practice to prevent suicide among the iron workers. And we try to solve this specific objective by identifying and prioritizing the employer-led practice to improve mental health initiative. Also, we conducted a longitudinal assessment of the Living Works, suicide prevention training program. So this is our method to identify the objective one. We started by doing an extensive literature review where we identified 70 employer-led practice from literature. We subjected this to an expert, interview. We interviewed 5 experts. They refined the 17, practice and, to 13, practices. And after that, we subjected it to a Delphi, survey. And this is the, procedure for a Delphi survey. And then we tried to, minimize bias in, our Delphi survey by randomizing the question. We asked them to provide a reason, and we subjected to anonymity. So also for the analysis, we tried to use the median absolute deviation. We used the Kendall W and the Cromba alpha to check for internal consistency and also to check for consensus in the responses. Excuse me. So yeah, for the objective 2, the longitudinal, study, we tried to do 2 training. The first training is on the safe work. So the aim is to recognize the warning sign of suicide and connecting at-risk worker. They perform a lot of activities like identifying the FABA behavioral cue, practicing revival technique, and and it was for 3 hours. The duration was 3 hours. Also, we did a training on the ASSIST program, and the aim was to advance intervention skill, including trust building and safety planning. And the activities include the role-playing exercise. They applied a PAM model, and we did that for 2 days, 14 hours in total. And these are the pictures from our training while we are training the specific iron workers. And after that, based on our objective 2, we try to, understand 3, research questions. Number 1 is, does the training enhance emotional well-being among iron workers over time? We try to understand that does participation in the training, the living works, and the safe talk improve iron worker suicide awareness? And we try to understand if there is sustained, suicide awareness improvements in iron work over time. And this is the methodology. This is the timeline. We collected the data 7 days to the training just to understand their suicide awareness and their emotional well-being. And we did that by following up with 2 days after the training. And also we did a follow-up after the training for, 36 days. And this is a variable we try to, measure the suicide awareness, the emotional well-being. And we analyze it using the linear mixed model, CDAC adjustment post hoc, and the mean difference. Excuse me. So I'll be presenting my results. So based on the, this is the list of the employer-led practices that were ranked. I mean, after we revise, we have the 13 list. The first one is train employee to dictate, and refer suicidal co-worker. We use role play to teach suicide crisis intervention, follow up after injury and suicide attempts, add mental health topic to safety training, and so on. Yeah, this is published in our reports, and I'll be explaining further in subsequent slides. So, and this year we present the result of the 3 Delphi round used to evaluate the employer-led practice. We could see that the Cromba alpha remain above 0.92 across all round, confirming high internal consistency. We could see that the Penda W, which measure the consensus, rose from 0.136 to 0.41 in round 3, which show progression from weak to moderate agreements. Also, we could see that chi-square were, statistically significant from round 2 to, round 3. And overall, we could say that this result validates both the reliability of the expert panel and the effectiveness of the Delphi process in identifying and prioritizing the impactful suicide prevention practice. So now let's take a look at the top 7 employer-led practices identified through as Delphi survey. The first highest ranked strategies was integrating mental health education into safety training. This approach was practicable, scalable, and helped normalize the mental health discussion in routine safety briefing. Also, it's followed by active follow-up after a workplace injury or suspected suicide attempt. And then the third was training employees to dictate, suicidal sign was seen as essential for early intervention. And also, return to work order was ranked high, and so on and so forth. So, and also we, on the objective 2, we have the mean emotional, we are trying to understand, does the training enhance emotional well-being among iron workers over time? But if you look at the results, we have the mean emotional well-being score. At first, there was a noticeable improvement from 4.31 pre-training to 4.88 post-training. However, by the follow-up, the score dropped to 4.5. Statistically, we could say that this was not significant, indicating that the training may not result in lasting improvements. And this we can, infer from these statements that the training alone wasn't enough for emotional well-being, likely require an ongoing structural support beyond a single intervention. Like we need an ongoing structural support to, enhance emotional well-being in the iron worker. And also for the second research question, we are trying to understand, does participation in living work assist and safe talk improve iron worker suicide awareness? We could see from the graph that the training shows significant improvements across several key areas with p-value that is positive. And also we could believe that asking about suicide increase. If you check this, asking about suicide increase rates drop from a missed score of 2.54 pre-training to 1.75 post-training. This shows that participants learn that open dialogue does not increase risk. In fact, it can save life. Next, the ability to recognize the warning sign also improve, from the pre-training to post-training. This actually demonstrates, the stronger awareness of verbal, behavioral, and, situational cue. And also we could see that there is a reduced might of asking about suicide increases rates. You can see from the pre-training is actually increases and then it drops. And then we could see that there is a significant improvement in the Living Work Assist program for suicide awareness. Now to our third research question, we are trying to ask, does suicide awareness remain sustained over time following the training? This graph actually tracks from pre to post, training, pre to follow-up, and post to follow-up. First, we saw a strong positive boost immediately after the training. Participants gained significantly in suicide awareness. right after the intervention. Second, while some of these improvements persisted at follow-up, the gain was smaller, showing, partial retention. And third, the slight decline, post-training and follow-up indicate that without reinforcement, some of this knowledge may begin to fade away. But, research shows that there was significantly improved, from pre to follow-up, sustained awareness over time. And in conclusion, we are able to identify and rank the employer-led practice to prevent suicide. We provide the empirical evidence regarding the long-term impact of suicide prevention training, but the limitation of our research can be due to, the small sample size, which may limit the, generability of our results. And also in the future, we recommend that, applying behavioral theory to test how practice influence workers' attitude and action is important. Also, we hope that we could actually develop model linking employer action to mental health outcome using theoretical framework. Thank you so much for listening to my presentation, and I'll welcome your question. Thank you.
Yep, thank you so much, Johnson. So that was the work that we have done. We have two main objectives. We wanted to identify a list of employer-led practices and rank them based on their effectiveness, based on the perception that people who are involved in suicide prevention have regarding these practices. And also we tested effectiveness of a suicide prevention training in a longitudinal study to see that how the impact will last. And as Johnson mentioned, that was really interesting. Opening up the conversation helps a lot. And something that I have learned, I think one of the key takeaways from these trainings is that if you see someone who might, that you become suspicious based on some of the signs that you see. You become suspicious that maybe this person is thinking about suicide. Maybe he is going through divorce, or she has some recent financial problems or things like that. You should ask them, are you thinking about suicide or not? And that's really helpful because you can detect these people. They don't think that they are alone. There is no other solution. There is no way out. You can start a conversation with them, and you can anchor them on some of the things that matters to them in their life. Maybe they have a children, maybe they have a brother or sister that they are thinking about, and they're thinking, okay, if I'm gone, what happens to them? You find this anchor point, and then you turn it around and send them to get some help and support from professionals. Yep. Thank you so much. And we are open to questions and discussions.
We're going to hold questions until after Brad goes. So thank you guys very much. Really appreciate it. And we will go ahead and turn it over to Brad. If Johnson, if you would stop sharing. Perfect. And Brad's up. That's perfect. Good. Good. Thank you.
Okay. Thank you very much for the opportunity to present today. So in the project we did, we evaluated the implementation of two very different peer support programs for mental health. These were done in the St. Louis area, and I'll briefly walk through the two different programs that we looked at. So the goals here are that many trade unions and contractors are implementing some form of peer support programs to better prevent suicide and protect mental health. We know that there are 1,000 points of light blooming out there, but there's little practical information about the barriers and facilitators for implementing these kinds of programs. So we sought to look at what happened, how it worked, and tried to get some lessons learned that might be useful to other people in standing up new peer support programs. So the first program was done in our Greater St. Louis Construction Laborers Health and Welfare Fund. So this serves two locals that have about 4,200 active members and about 7,000 retired members and dependents. The Lean STL program, it was based on the Laborers Escaping Addiction Now program, which was pioneered several years ago in Boston. The Boston program was originally focused primarily on addiction. Our program here included an expanded focus to address suicide prevention and a variety of other mental health topics as well as addiction. In this model, 2 peer counselors were hired in March of 2023. So these were both long-term laborers who had lived experience with addiction or mental health issues. They were extensively trained, getting over 200 hours of training, and including the list of trainings that you see here. Basically, these 2 were to serve as the peer counseling resources for the union and their retired members and dependents. So the key activities of the peer counselors were to provide advice and referral to individual workers and dependents. They did a series of job site talks, taught classes in the apprenticeship, served as the interface between the union members and their member assistance program. I think member assistance program and employee assistance programs are not always easy to access and can be frustrating. So they served as the sort of concierge to try to get people the services that they needed, helped members to get access to union-sponsored benefits, as well as to community resources. And we forget that there are a lot of community resources available as well. They can be hard to find. So this is where someone who's knowledgeable about available resources can be helpful. They reached out to contractor associations and in general worked to try to create and sustain a network of support for the union members and for their dependents. Our evaluation primarily focused on issues with implementation and perceived success of the program. So we did semi-structured interviews with 15 union leaders, business agents, and trustees. Covered a number of domains. Some of these are highlighted here. So adoption and buy-in was a major focus. This was actually relatively smooth. There were some initial concerns about cost, but in general, this was highly supported by the union and its members, and people realized that there was a problem and were really happy to be doing something about it. The impact and the satisfaction were also high. And one thing we found is that personal stories were really key to the perceived impact. I think very few people we interviewed talked about things at a population level or how many people had been helped. Almost everybody, though, had a personal story of one guy who got helped, and that shaped their perception of the program. With awareness and utilization, we found that really continuous communication through many channels was key. And it was remarked multiple times that the lived experience of these peer connectors, both as people who had had a mental health issue and as people who had been active laborers, was very helpful to reducing stigma and encouraging utilization by their union members. So it was easier to approach, easier to talk to, and this was seen as an important step by many of the respondents. The program was well accepted, and this peer support approach was seen as particularly effective. Being able to talk to someone who you knew or who was like you was easier to do and easier to initiate than talking to someone on the other end of the phone who you never met before. The sustainability was an issue that was of particular concern to us. When we asked about whether the program was sustainable, we got looks like, of course it's sustainable because it has to be. And I think the union members and leaders see this ongoing need for mental health and substance use support. They think the program is highly relevant and it's going to be that way for a while. It's going to need to evolve over time to meet the needs of the members, which it has over the last couple of years. But the laborers really seem to be in this for the long term for this type of peer support. The cost and feasibility, basically all stakeholders thought that the benefits far outweighed the costs. It was a future challenge or areas of improvement was the likely need for additional staff as the program grew. There was also concern about the peer support, people getting burned out. They are very busy guys. As the program grows, the demands are growing. And so the maintaining the mental health of the people who are providing mental health for their union brothers is a definite concern. And then the next steps is that we would like to interview and find out the experience of people who have sought assistance through the peer counselors. Other evaluation metrics here is we saw increased utilization of the health plan and member assistance programs. The number of health plan claims for mental health or addiction issues increased by 20% in the year following program implementation. So this was seen as a win because we know that mental health and addiction services are underutilized, and seeing a boost by 20% once we had these Pied Pipers for mental health out in the labor community. This was seen as a marker of program effectiveness. Program continues to thrive and they're looking now at how to expand it. So this was program one. Program two was quite different. This was done through a local construction corporation, and we adapted the Australian suicide prevention program, Mates in Construction, for application to the U.S. construction industry, with the goal of improving awareness of suicide and to increase help seeking for people who were in crisis, and help offering and referral through their work colleagues and work structure. So Tarleton is a general contractor in the St. Louis area. They have about 250 permanent employees. They run about 24 job sites. They employ union carpenters, cement masons, laborers, and iron workers. And they have been participating in our local suicide prevention stand down since 2019. So the St. Louis area, in collaboration with us and the Association for General Contractors and some of the major employers, have been doing a September stand down for suicide prevention since 2019, usually in the second week of September, Suicide Prevention Week. So we looked at the Australian Mates program, which is been going for about 15 years. It's run by a well-funded independent trust and consists of 3 levels of training and a number of other case management and other supports. So our program consisted of 3 levels of training. Like the program we just heard about, we used the Living Works training. So the HR and the safety managers got a 2-day assist training. We chose a number of peer connectors to get half-day safe talk training. And then general awareness training was delivered to all of the workers at Tarleton. Instead of the 1-hour single session training that the Australian Mates program does, we did 5 days of toolbox talks. So they had 10-minute talks over 1 week in September. There were hard hat stickers, resource cards, and other sort of reminders handed out. There was a final toolbox talks several months later, sort of reminding people of the program. And then we did interviews with people who had been trained in the assist or safe talk training several months later. So our interviews include HR, workforce management, superintendents, and safety managers. Again, value of the training that was seen as high. The training was seen as valuable and useful. It increased the confidence of people who got the training. And a recurring theme here was that real life practice was needed. A number of them had already used their skills when interviewed a few months later. There was general consensus that empathy, observation skills, and awareness of suicide had been increased. And that some of the attention that we paid to support systems and referral had made it easier to connect individuals to the right resources. And I think in construction, this is a particular barrier because you may have 5 different unions on site. All of them have their own membership assistance program. And so when an iron worker needs counseling and a carpenter needs counseling, we're sending them to different places. So just keeping track of who gets what benefit can be a challenge. So we worked with Tarleton to make basically laminated cards that gave the numbers to call for every different trade that was going to be on their site. So if somebody was in need of services, people knew who to call. The some suggestions for future here was to share success stories and basically try to build out a peer network for the people who were doing the counseling. To do training in the future that addresses specific needs of diverse populations, like women workers and minority workers. Overall reception, the worker reaction to the general awareness training was reported as neutral to positive, which actually was seen as a win compared to their usual reactions to training. Over time, receptivity to the program was increased. Several people noted that stigma about discussing mental health was seen as decreasing over time after the training, and that the peer connector network was seen as beneficial in making support more accessible and trying to create a culture of openness and support on site. So since these two studies, we've done some more follow-up with the MATES adaptation. So we worked with Diane Rollman, who's on the call here today, to implement a second pilot program at United Directors in Des Moines with very similar results. We now have a grant from CPWR to implement and evaluate this MATES adaptation in 6 different construction contractors. Initial training is underway at 2 contractors in St. Louis, and this afternoon we'll be going out to one of them to do the first round of pre-training surveys. So if you scan the QR code, you can get more information about our programs. We have a 12-page report up on the CPWR website, and then want to give many thanks to CPWR, to the laborers in St. Louis, Tarleton Corporation, the Association of General Contractors, to the Healthier Workforce Center of the Midwest, Dan Rollman, and the United Directors in Des Moines. So thank you very much.
Thanks, Brad. And then we've got just a couple of slides on CPWR resources, and while Jess pulls those up, one of the comments that we got was shout out to Massachusetts Laborers Lean Recovery Program. Mark, Glenn, and John do great work. And I agree with that comment from everything I've heard. I haven't met these gentlemen. However, the study that Brad was talking about is the laborers taking that successful Massachusetts program and moving it to the Midwest and seeing how it worked. So we're really excited about that study, and a lot more. Just throwing up the resources that we do have. We have basically our resources on mental health are out there for free, available to everyone in the industry. We've broken our mental health resources up into a suicide prevention page and an opioids resources page. We have free training materials that are there for download that can be used at any time, and we will give people train the trainers if they want to use it. These are more discussion-based training programs. The opioid awareness training program was developed under the leadership of the NAB2 opioid task force, and it is available for free for everyone from our website. That's more of a traditional PowerPoint training with presentation and facilitators guide. We have a new newsletter in the last year called Reason, trying to get at the good news of people who are dealing with this issue head on in our industry. I owe everybody the May issue because things have been utterly chaotic at CPWR's world, and I haven't reviewed it yet. And it was supposed to announce this webinar, so we sent it out other ways. The next slide hits on this study is one of those 5 papers or research projects that I talked about, and all these papers, the full reports of these studies are up on our website on this link, which has also been popped into the chat. The previous webinar, I think, is really important to highlight too, because it will answer some of the questions that have been asked in today's webinar. And then our data center is magnificent and really does a great job characterizing the industry and what we know from national data sets about these issues in our industry. And with that, I'm going to go to the questions and answers. And the first one that came in on the registration is really an example of how great our data center is, our data analysts actually had to answer this for us. And the question was, what is the primary and secondary methods of suicide in construction, and how is suicide determined as opposed to an incident? And the answer is the NVSS, National Violent Something Reporting System. Somebody help me out there, Brad. Mortality data allows us to identify the means of suicide or the specific method of suicide using the cause of death codes. This was included most recently in September 2024 data bulletin that we put out from CPWR. If Jessica dropped the link into that, in the data bulletin, that was chart 11. Firearms accounted for 53.3% of suicides of construction workers in 2022, and the second leading means was suffocation, which accounted for 34.3 suicides. And the link to the data bulletin is right there with that kind of detailed information in there. The other part of the question was, how do you know these are suicides? And these are coded within that NVSS system with the ICD-10 codes U03, X60 through X64, and Y87 if you are an ICD-10 geek. So that's how we did the analysis to bring you that answer. There's a couple of other questions that came in ahead of time. One is, I'm gonna, there's a couple, and I've kind of flagged Brad for several of these. What is the best proactive program to address mental health and dealing with the macho man thought process? And then also how to get buy-in to work with the trades and contractor partners. So it's kind of like a two-part question. If you could talk a little bit about that, Brad.
Sure. So I think that the question about what is the best program to use in this population, I think we really don't know. There are several programs that I think have been quite successful. So the QPR, the Living Works training that both Dr. Esmaeili and I have used, mental health first aid, which we've had success with here and had classes sponsored by our local AGC. So these all these sort of national programs, they're quite similar. You know, they're a bit different in the details, but they're substantially similar. So I think doing any of these major programs is way better than not doing anything. It'll be a while before we have data that says one is better than another. But I think it's whichever one speaks to the people that you want to, you know, that you want to take it. And again, any of these I think work pretty well. This sort of bleeds in the next question is, how do you get buy-in from construction in sort of macho group? It's, you know, I think a lot of the buy-in has come from just looking at the numbers, you know, with, you know, 6 times more people, 6 times more construction workers dying from suicide than dying from workplace fatalities. You know, we think of all the effort that we're spending to prevent fatal injuries on sites, and, you know, this is killing 6 times more people. So I think, at least in our region, pretty much everybody's on board that this is a real problem for the industry. It's been a 180-degree change over the past 5 years or so. And I think people now are talking about it. And I'll just say, with construction workers, I think the only thing harder than getting them to start talking about something is to get them to stop talking once they get going. And I think we're sort of in that, we've broken the ice, and I think people are really talking about this a lot locally.
I think you're right. Behzad, did you have anything to add to that question? And you're on mute.
Thank you so much from Dr. Evanoff, and thank you, Brad. A great explanation. My only add-on is that if we just break, as Brad said, if we just break the ice, people will see that they are not the only people who are going through this hardship. They are not the only people who might feel isolated, that there is no solution for their problems, or maybe suicide is the only solution for their problems. People might be macho, but still they have these problems, right? So if we have these trainings, if we have these talks that someone who had experience come and talk with the just group of workers and said, hey, I had this experience, I went through this, I survived, and now I'm providing help for other people. Definitely those people, even if they have a macho culture, they will feel that, hey, I can talk with someone. Hey, I can start talking about this. I can be open about my feelings. And I think that can help a lot. Because most of these people that we went through the training and we talked with them, they were macho people. They are very capable workers and do very hard work. So, but they could speak about suicide very easily, and they were trying to help other people. I think that's really important.
I think that's great. And I think, Brad, you talked about that this awareness training is it doesn't really matter the brand, you know. I'm seeing in the notes or in the comments like QPR and different types of awareness. Mental health first aid is the one you were talking about. They're all kind of connected. Oh, and the American Foundation for Suicide Prevention is launching a new construction aimed talk. I can't remember the name of their program, but I mean, all of these programs are kind of this awareness training for suicide in particular that really is somewhat equivalent. And you know, it fits in with this schema that we collectively at CPWR have been believing in, because we see it works. Is you need to really train everybody on the issue, on awareness, but then you need to train higher levels of people in our industry for a lot of different reasons, but really because you need people to connect people in crisis to care. It's not a simple thing if you're in crisis to try to find your EAP number and try to find an appointment. It's more about trying to walk people to care. And that's where some of these peer programs and the profiles we've done on peer programs really come into play. And I'm going to refer you to those 5 studies again, because 2 of the ones that we reported out in March are on peer programs. The third one, well, I'm going to talk a little bit more about that, but ask if anybody has some, you know, opinions about this kind of connection between pain, opioids, and suicide. You know, Brad talked about the fact that 5-6 times as many construction workers die by suicide each year as die from traumatic injury on the job. Well, you make that into 15 to 17 times when you add in overdoses. So these things are obviously connected, and I don't know if you had any comments on that. I was going to throw some comments out after you do.
I'm sorry, was that for me?
Yeah. Any comments on the connection between pain, suicide, opioids?
Yeah. So opioids are a known major risk factor for suicide. So we know that people are using alcohol or other drugs are across the board are at much higher risk of suicide. Construction workers, we know, are at much higher risk of opioid addiction than the general public, related at least in part to the fact that they get their bodies beat up. And people in my profession as an MD were for years handing out opioids like candy. And many construction workers don't get paid if they're off work. So if they're, and the work is seasonal. So if work is available, you want to work whether you're hurting or not. So a lot of it, construction workers end up with substance use issues because of work-related injuries. So that's a major risk factor. So I think the two are, the two are really inextricably intertwined. The more opioids you have in a population, the higher risk of suicide.
Great. I think that, you know, some of the data bears that out as well. We saw in one of the studies funded under this special cycle from of funding was from Jonathan Davis at University of Iowa, who looked at the impact of state laws on and other factors on suicide outcomes in construction workers, and found that hold on, I just pulled it up, so I don't want to misspeak, but I probably will. Male construction workers had lower rates of suicide when laws restricting opioid prescribing practices were present.
Right.
Construction workers were more likely to have substance use contribute to their suicide compared to workers in other occupations. So again, if he presented his reports in the oops, that's the wrong page, in the last webinar, and if we can, I'll find a way to link to that report as well. So the other thing we found was there was, an earlier study of suicides in Utah among construction workers. And I think it was 10% or 25% of those workers had opioids in their system. So while their death was ruled a suicide, they definitely had opioids in their system. Brad, the question was, and Behzad too, you both dealt with the this issue from the kind of union side, but also from the employer side. The question was that came in, did any of the studies include non-union workers and how they relate to union workers? Can you comment on that? Either, or Behzad, why don't you go?
Sure. I go first. Unfortunately, we haven't collected data from non-union workers, but I think that's worth studying, and they're definitely collecting the data. For the union, based on my experience when we were there, so they are more connected, and also the culture. We were discussing the difference in culture between the carpenters and iron workers, and how that might also lead to different rate of suicide or different problems that they might face. And but unfortunately, we didn't collect any data on non-union workers. If CPWR provides fundings, we would be happy to do that, to conduct that study.
Well, CPWR is hoping to provide more funding to study all of this work if we have funding, Behzad. That's the big question mark. Brad?
Yeah, so to date, we've worked mostly with employers who employ only union workers. We're actually we're going out this afternoon to Emery Sapp and Sons, which is a big road construction company. That's an employee-owned company. So we're trying our first implementation in a company that's not a union company. So I don't know how different it's going to be. Obviously, the unions have additional resources outside the workplace that the non-unionized settings don't have. So we'll find out.
Great. Just I noticed in the chat, thank you, Jessica, you found the link to the AFSP's new program on suicide prevention, and we're really interested in helping them roll it out because it will be available at no cost from what we understand. The other kind of set of questions talks about the availability of mental health care from licensed psychologists to other types of experts. And, is there any way to universally find those types of care? And your experience in trying to kind of suss this out would be great to hear.
Yeah. I don't think there's anything universal in the American healthcare system. Which is
you are a physician, not just
I'm a physician. Yeah, and actually married to a psychiatrist, and both my daughters are psychiatrists. So
crap.
I've heard some theories. But 50 years ago, Walter Cronkite said that the American healthcare system was an oxymoron because it's not healthy, it doesn't care, and it's not a system. And I think that unfortunately is something that is discovered by people, and particularly when they have mental health issues, that it can be hard to find appropriate services, hard to get in. A lot of EAPs or MAPs, you're limited to some relatively small number of visits, and we really do have a crisis of access to mental health care in this country. So I think there's no great easy solution. You look at what your insurance will cover, what your EAP or MAP will cover, and you're kind of in some ways at the mercy of your healthcare providers.
Yeah, I really think that's true. And I feel as though because it's so varied, if it's employer-based or if in construction, you may have multiple employers. If you're a union construction worker, it's through your joint labor management fund. And the benefits of the person next to you on the job site may not be the same as yours. So there's no one way to figure it out. And I'm just going to kind of go back to prevention and thinking about number one, education in the prevention space, but also in the, multi-tiered support system that's, advocated through MATES and some of these other programs, is really kind of a bridge to help people find care when they really need it. Other times it's just, having a peer to speak to who's been trained and is responsible. So I think that's a really important point. And I think the last thing I wanted to comment on is thinking back to the question of union versus non-union. I think the results are really applicable from the employer perspective of both of your studies. Between Behzad's study and Johnson, describing the Delphi method used in interviewing employers to find best practices or good practices, is regardless of union status, as well as the approach that Brad, you took with the firm in rolling out this training program. I think that it's definitely applicable. So with that, any closing thoughts from either you, Brad, or Behzad?
Behzad, you want to go first?
Sure. No, thank you so much, Joseph, for the closing remark. I think this is a really important issue. And as I'm talking with people, each suicide is not only one person's decision, it impacts many people around them. And it's more likely for people who have seen other people commit suicide or one of their relatives to get involved into that. So this is an issue that can keep spreading in our society, and we need to address it. And as we move more toward our society is moving toward we are not tribal anymore, so it's become more common, these mental health issue that should be addressed. And I hope these studies can help and provide some impact, or at least a start to have an impact. Thank you.
Thank you, Behzad. Brad?
And I would say, I think that the numbers really speak for themselves. Construction companies are uniquely, construction populations are uniquely at risk for death by suicide. The industry has responded, I think, very enthusiastically. 2 years ago, there were almost no construction-specific models out there other than the Lean program and the Australian MATES program. And now, just in the chat today, there's at least half a dozen programs specific to construction. So I think choose one and run with it. So another thing we're working on as an output from our work is a sort of playbook on how to implement a program similar to the MATES program, a peer support program, on your site. So that should be available through CPWR in a month or so. And it's sort of maybe worth looking at, especially for some of the bells and whistles that go around the education program. Some of the other things that you need to do to provide referral pathways and make sure that you're set to provide care to your workers.
Thanks, Brad. Appreciate that. And like we wish to, we do some of this work with private funds, like the studies that we reported out here, but most of our funding comes from NIOSH. And for those of you not in the know, NIOSH has been decimated. And we're uncertain of our future funding, including the funding Brad talked about in his multi-year study on trying to implement MATES in the US. So this is important work, and we really hope to continue it, and appreciate both of you and your teams, and thank everybody who tuned in today, and be on the lookout for the follow-up for this in the emails. Thank you very much.
Thank you so much, and big thanks to CPWR. Your institution had a significant impact on safety in construction industry. Really appreciate it for all support. Thank you.
Thanks, Behzad.
Seconded.
Bye-bye.